So today actually is whole thing about with the mother, discussing with the mother how breastfeeding works and assisting the mother in getting her baby to latch and help her to overcome her problems. Now, the last class we had spoke about step 4, which is actually uninterrupted skin-to-skin contact and supporting mothers to initiate breastfeeding. This is one of the sentinel indicators which they have taken. Because once you start right, we all end right, isn't it? So that is one of the sentinel indicators which they have asked for. And the next would be, of course, exclusive breastfeeding when they leave the hospital. So in order to achieve exclusive breastfeeding, we have to go to the further steps, some step 5 to step 10. I am dealing mainly with step 5, 7, and 8 today. So first of all, after having taught the mother antenatally about breastfeeding and its benefits, now the mother and the baby are here with us and we are going on the postnatal rounds. And there it is a time to talk to the mother about how to continue the breastfeeding after her early initiation, feed the baby according to the cues and not to keep a strict time schedule, encourage her to feed in the night, no prelactal feeds, teach her how to get the baby to latch and teach the positions for breastfeeding. Do not separate mother and baby unless medical reasons arise. Treat the common problems in breastfeeding and help her to feed. All our knowledge has to be communicated well to the staff nurse and the health workers, especially the mother, so that they make it a skill and they practice it well. So she goes home and continues. So this is the importance of the whole thing. Now, these two slides are coming up again and again for us to just remind that there are two hormones which play important roles here. Prolactin. Prolactin actually is already there when the mother is pregnant and when the baby is born. But we know that once the baby is not feeding at the breast, these levels come down. So that is also an important scientific evidence that we have to keep the mother and baby in with rooming in with the baby, skin to skin contact. All this is scientifically important because the prolactin hormone is necessary for sustaining the milk supply. And we also should remember to tell the mother to feed at night because more prolactin is secreted at night. Then, of course, the oxytocin is there whenever the baby sucks. It's a letdown reflex. So this is also another important hormone. And then oxytocin, the importance is that whenever the baby is with the mother, bedding in with the mother, when the mother is touching the baby, the reflex comes. And what hinders this reflex? Worry, stress, pain, doubt. So if you are going to take the baby away from the mother soon after birth, initiation, and then the baby goes to the ICU because the mother goes to the post-operative ward, then what happens? These hormones are not in play. So that is the importance of knowing the rooming in. Now, the mother also has to be taught about the dangers of prelactal feeds. Very important that if you're going to give anything this other than breast milk, infection risk is there. Then the baby feels already saturation, is not going to suck at the breast. Then less breast stimulation, and the bottle can act as interfering attachment, and therefore more difficult to establish breastfeeding. Now, another inhibitor of breast milk is the breast milk being full again. So if the breast is not being emptied, there is a self-regulatory mechanism. So that itself acts as an inhibitor. So if you're going to put the baby away from the mother, somewhere away, so the mother's breast is full, she can't feed, so there again, breast milk comes down. Now we go to a case study. Mrs. Malati had a baby boy yesterday, and she says she has been trying by herself to put her baby to her breast. She could not attach well, and now he is having difficulty to feed at the breast. She tells that she will have to bottle feed. And now a nurse has now come to help Malati to attach the baby. The nurse puts the baby to the baby's face to the mother's breast. The nurse then holds the mother's breast with one hand and the back of the baby's head with the other hand, and she tries to push the baby onto the breast. Now the baby pushes the head back and starts crying. Now what went wrong? This is a scenario very often we've seen. Now, always remember when you go to a mother, as we're also discussing, whenever you go to a mother, you greet the mother, ask her how the feeding is going on. We just don't go just like then ask her to, touch her breast or body parts and say, let me show you. No, you have to be modest, greet the mother, ask how the feeding is going on, look at how she's feeding, assess the breastfeeding first. Then you can ask her whether you can help her, whether you will be like to show how to breastfeed. and make sure she's comfortable, relaxed. Sit down yourself in a comfortable, convenient position, just directly opposite to the mother. Explain how to hold the baby. Maybe with the doll, you can explain the 4 key points. That is, the baby's head and body is in line. The baby is held close to the mother's body. Baby's whole body is supported, and the baby approaches the breast nose to the nipple. Now, you can show how to support a breast only if necessary. And usually supporting of the breast, I will again show in the diagram, which should be with the thumb above and the fingers below. And the fingers should not be too near the nipple. And now you explain how to help the baby to attach, which I will be showing in a diagram. Now, let us see how she responds and how she feels. And look for signs of good attachment. If the attachment is not good, try again. So this is how you all have to help a mother. Now, this picture tells you how the baby should be in line and how the baby is sucking, and the mother is having one hand is also free now. She's able to hold. Now the baby is very comfortable. This is a very good position, picture of a baby is well positioned, straight line, and the baby is sucking well. Now, attachment is the key to successful breastfeeding. This is why we have to spend time with the mother. When you have to observe the mother and where she's going, making a mistake, you have to see, and then only we can teach her. Okay, so instead of simply taking a class and this is how you're going to do, and no, we have to be practically imparting that skill, and that is why we are here to learn today. Now, attachment is the very key to successful breastfeeding, and you could see here how the mother is holding the breast in the diagram, the thumb above and the fingers below near the chest wall, and she is trying to touch the lower lip of the baby with her lower portion of the areola, and that is where the contact point occurs, and then the baby opens the mouth, and then you can see that the nipple and the areola is going in very neatly. So the breast will mostly completely go in. So this is and then only when this triggers the baby's sucking reflexes. So this is a very important picture which should always be in our minds when we start breastfeeding. And of course, when you communicate to the mother, the posture, how you sit, the eye contact, remove the physical barriers, and then taking time without any hurry, talk to her. And touch her in an appropriate way. Do not touch her breast or baby without her permission. So this will give her a confidence that you're listening to her and that you're interested in teaching her how to breastfeed. Now, how should the mother hold the breast? This is very clearly seen, resting the fingers on the chest wall so that the first finger forms a support at the base of the breast. And a bad position will be to hold just the nipple. Now, we all should know what is good and poor attachment. It's very clearly seen that in this picture. How in the second picture, only the nipple is taken in. And when you see externally, how would you see it? You would see that in a good attachment, the mouth is wide open, isn't it? So again, we'll talk about it. This picture should be in our minds. And in poor attachment, the nipple alone is attached. So good attachment means more areola is visible above the baby's mouth than below. The baby's mouth is wide open and the lower lip is turned out and the chin is touching the breast. Whereas in a poor attachment, the less areola is visible above the baby's mouth than below. And you might see equal amounts of areola sometimes. The mouth is not wide open. The lower lip is pointing forward or turned in, and the chin is away from the breast. So more areola is visible above the baby's mouth than below. That is what is good attachment. Now, what happens if we don't teach the mother proper latching? Many of our problems today, which the mothers face, is because of improper attachment and latching. I'm sure all of us will agree on that. And the mother has painful nipples. The baby is just sucking at the nipple, and then damaged nipples. Then there's going to be engorgement because only sucking at the nipple, the milk is not reaching the baby. And baby is unsatisfied and crying a lot. Baby feeds frequently for longer periods of time. Then again, when the milk is full, engorgement is there, milk production comes down. Baby fails to gain weight. So you see how important is that attachment and latching are taught to every mother. Now, all these reflexes in the baby, the rooting reflex, the sucking reflex, the swallowing reflex is there. But the mother has to learn. It's a skill. She learns to position the baby, and then the baby learns to take the breast. Now, just to have a questionnaire form of it, how to help a mother achieve an effective and comfortable latch? Let us learn some 5 points on that. For the latch, make sure the mother brings the baby to the breast and not the breast to the baby. The baby should be brought to the breast. Infant's mouth should be wide open. Infant's chin is touching the breast. More areola visible above the baby's mouth and below. Lower lip is averted. Infant's cheeks are full and no dimpling is evident. And nipples are intact and are not pinched after the feeding. These signs will tell you that you have a baby has a good latch. Now, we all are familiar, most of us are familiar with this latch assessment tool. Please go and look. I'm not going into details or lack of time, but this is a very good assessment tool with the acronym called LATCH. If we can use it in our wards, it is very useful. You will know how to use it when you use it again and again, and it will clearly tell you where you are. And scores less than 5, that means that mother is not doing well. Scores less than 7, please try not to discharge the mother. Teach her it again and again. More than 7, maybe not reach 10, you can ask them to come back for a review. Latch score is something which we all have to learn. Latch L is latch on. And if the baby is sleepy or reluctant or not having a latch, that means it is 0. And if his repeated attempts are necessary, it means it is 1. And for the breast, complete grasping of the breast with full latch, that means it is 2. For every thing, you have 0, 1, 2. And audible slowing, there is not there, it is none, 0. A few with stimulation, it is 1. And spontaneous and intermittent frequent stimulation, swallowing, it is 2. The type of nipple, here they're given inverted, but now inverted nipples also we're able to feed. So that is there. And 1 is flat nipple, and then 2 is averted nipple. Then comfort is engorged, cracked, bleeding, large blisters in a breast will actually hinder breastfeeding. Okay, so if that is there, then you're going to give a score of 0. And if the filling, reddened, small blisters are there, it's 1. And good breast that is soft and non-tender, you'll give a score of 2. And holding the positioning, if the mother has to be fully assisted all the time, it's 0. Minimal assistance is 1, and 2 is no assistance. So here, you can do a latch score on day 1, maybe just to assess how the mother is doing. And then if you teach her, and then you can do a latch score in successive days. You can decide what to do. And when the mother is being discharged, or if you even before discharge, you can have this latch score and understand whether she's fit for discharge. So if she's less than 5, I don't think the mother is doing well. Okay, I'll tell you once more. I have a checklist also. I'll show you how to assess the mother, how she's doing. So with that, again, you have to feed the mother, and she's not yet ready. Now, with a latch score of less than 7, I would still hesitate to send her home because she will not be confident to do that. And a latch score of 9 and above, definitely they can go home. But a latch score of 7, even if they want to go, some people want to go anyway home. So I ask them to come back for a review because I'm sure they may land up in a bottle feed. Am I clear? Yes. Now, going in for rooming in mothers and babies together day and night. So this is also a very important issue, because the mothers are just learning. I was recently talking to my niece and she said, "Auntie, this is totally new. Another person in my life. I don't even know about her." So why should we separate mothers and babies? They're just learning how to understand the baby, and the baby is understanding the mother, and the mother is understanding the baby. And this will help in establishment of breastfeeding. And it helps in mother and baby's bonding and attachment, and enabling frequent, unrestricted, responsive feeding. We'll learn about responsive feeding in the next few slides. And increase infants' and mothers' well-being. See, when the baby is with the mother is not stressed. If she's not stressed, the hormones are playing very well. And of course, we know that if infection rates are less than babies who are roomed in, because if you're unnecessarily putting babies in the ICU where the bacterial flora itself is different, you're bringing in more infection to these babies. So it's always when the babies are with the mothers, normal bacteria is there and the babies get less infection. That is why now in latest events are happening that the mothers are going to be in the ICU. It's called mother and NICU. So such importance is now bringing. So I think we'll not have any difference of opinion now. The mothers are going to be in the NICU. We may be having new ICUs where the mothers are also coming in. Now, advantages already told you. So breastfeeding is longer. Babies gain weight more quickly. And here we are talking about cradles. This picture I put in because in many hospitals, they have cradles. But usually in a country like us, it's better to promote bedding in. Okay, in case we need some phototherapy or other issues, we may still need these people. But as Dr. Jason sir was saying, we can have a bigger bed or a extra bed coming in rather than having this, so the baby is with you. So that is important. The next step would be supporting mothers to recognize and respond to the infant's feeding cues. Now, here along, we've been learning that we write always demand feeding, but that's slowly changing. Now, the mother has to be taught to know the baby, how the baby is looking for milk. That is called baby's signals or baby's cues. On average, if the baby is fed well, okay, at least 8 times they feed. Some infants may need more frequent feedings. And now we are talking about responsive feeding. Now, what is responsive feeding? Now, responsive feeding means mother is learning to respond to the baby's cues, baby's signals. The babies will be opening the mouth and turning the head, trying to find the breast, and they're wakeful and restless, making small noises initially. Then they start bringing the hands to the mouth. Then they start sucking. So this picture, I think many of us know, early feeding cues. That means the baby is saying, I'm hungry, okay? And that is stirring, getting up, mouth opening, turning the head. Then you're going for, I am really hungry. By the time, if you don't feed them, then I'm seeing that when you go for postnatal rounds, the babies are crying. That is a late cue. So you should tell the mother to start feeding in the early feeding cues. When the baby is trying to turn the head, opening the mouth and stirring, that is where we should start. And by the time it's mid cues, many babies are get angry. So at least by mid feeding cues, I'm really hungry. But if it's going to be late cues, babies will refuse sometimes. And we are all stuck up and we do not know what to do. So that is why mother has to learn, baby has to learn. So if you're going to separate a mother and baby, when will she learn? So this is just a question. Describe at least 2 early feeding cues and 1 late feeding cue, just to refresh ourselves. Early cues are babies waking up slowly, salivating, rooting, putting fingers or fist around the mouth, vocalizing. Late cues are crying, and then the baby goes back to sleep. Sometimes in the late cues, baby refuses to feed, and then they just sleep off because they don't not having any milk or energy. So then there are certain behaviors. You can teach the mother 4 pre-feeding behaviors, which before the babies really actively suck at the breast. That is, the pre-feeding behaviors are a short rest in an alert state to look at to settle in the new surroundings. They bring the hands to the mouth and making sucking motions and sounds. Then they start touching the nipple, especially when the baby is put on the mother's breast. They start touching the nipple with the hand. Then they focus on the dark area of the nipple because of by sense of smell, and it acts like a target, and they start moving towards the breast and rooting. This is all a normal pre-feeding behavior. Then finding the nipple area, attaching with a wide open mouth. So the advantages are many in responsive feeding. We don't find engorgements anymore. We don't find this mastitis. We don't have sore nipples. If the latching is good, breastfeeding is more easily established. Milk comes in more, babies gain weight. So as I've told you, what is important here is the attachment and the latching. Now, who's going to tell the mothers? Who's going to help the mothers? This is our problem. So the technique of breastfeeding is latching, attachment, and one more thing is the proper positioning. So position of the mother can assume actually any position that is comfortable to her and the baby. She can sit or even lie down. She should be relaxed and comfortable. Back should be well supported. Often we see mothers leaning towards the babies, which is not good. They get a backache. So she should not be leaning. And these are the breastfeeding positions. The normal position any mother is usually taught is the cradle hold. But nowadays we teach mothers other positions because many of them are not comfortable cradle hold. Difficulty in latching, especially when they have retracted small nipples and difficulty in latching. The cross cradle, because the cross cradle, you see that the mother has a good hold of the head. It is good for the mother. She can have a control over the baby. Then, of course, cesarean mothers, you can ask them to lie down, and even normal mothers, once in a way, or if they want, they can still lie down on the side. Then you have the football hold and the laid back positions. All these positions, we can teach the mothers even in the antenatal period, so they can choose their positions also. And other sitting positions we have to emphasize is the underarm position, where the baby is kept on a pillow under the arm and is useful for twins to hold them together. and to remove milk from all areas of the breast, and for small, sick babies and low birth weight babies. Both these cross cradle and the underarm positions are good. And the football hold position is good for, especially for twins and small babies and cesarean babies. A picture very nicely depicting the football hold. Why it's called football is the mother is able to hold both the heads simultaneously. So I think attachment and latching I have covered. Now let's go to some milk supply challenges we face. What is the normal challenges we face in our postnatal rounds and the challenges that a mother faces during her journey of breastfeeding. Mrs. Bharathi delivered a baby by vacuum extraction yesterday. Her baby has a bruise on her head. When she tries to feed her, she cries loudly and pulls away. She's very upset and feels breastfeeding will be too difficult for her. You watch her trying to feed her baby and you'll notice that her hand is pressing on the bruise. Now, how can you help her? Now, here is the challenge. Help her baby to take the breast. Let her position her baby in a calm and unhurried way. Show her the reclining position so that the baby's head is coming on top. Avoid pressing the back of the baby's head or pressing on a painful place. If the baby is rooting, let the baby continue and explain that the baby is trying to find the breast. And when the baby is near the breast, express a little milk into the mouth. And when the baby seems interested, help the baby to attach to the breast. Be patient and do not hurry. So here again, we are going to see how the mother is feeding and help her. It's not just going and just telling her and just going away. So why do babies cry and why are they reluctant to feed? There are many reasons. And out of that, we know in preterms are difficult, sepsis babies are difficult, those have asphyxia. Then, of course, they have a blocked nose. Many times we see them, it's very common. Then sedation or vacuum and forceps delivery. But here, the technique, difficulty, the breastfeeding technique itself is what is a major thing. Separating the mother from the baby after delivery, she takes a longer time to study. She's not getting milk because of poor attachment, poor techniques taught for positioning attachment. Then that leads on to engorgement and mastitis. Then the oversupply of milk comes in. And then the use of bottle and artificial teats actually hamper latching and attachment. Then babies may cry for so many reasons, isn't it? Discomfort because of some nappy, dirty nappies or wet nappies, hot climate, cold climate, tiredness, illness or pain. For the mother having pain also is a problem in feeding. Then hunger, poor attachment, not getting enough milk, and mother's food, maybe some foods she eats, and mother on drugs. You can think of other reasons also. So how do you deal with a crying baby? So again, we're going to listen and learn. If baby is crying frequently, look for a cause, take a proper history, assess the breastfeeding session. Every time you're called to assess to the ward to address this, please assess a session. Examine the baby, build the mother's confidence and give support and ability to care for a baby. Accept what mother is feeling about it. Praise what she's doing well. Give the proper information, help her to assist her and to latch and attachment. Make simple suggestions and give practical help. This is a common thing for every time you see a mother. Now, how do you know that a baby is getting enough? Many times we say mothers say that they're not getting enough milk. So we have some signs. Baby sucks regularly, rhythmically at the breast with occasional pauses. Rhythmic swallowing is seen or heard, at least by the mother. She tells you many times, I can hear it. Breast can feel soft after the feeds and regain fullness in between the feeds. Urine output is progressively increasing. Number of stools is progressively increasing after the first day. And the stools are changing from meconium to yellow. Baby appears satisfied, not crying. And the weight stabilizes by day 4. Now you can ask your staff to assess these things and the nurse and find out if the baby is having regular adequate milk supply. Then, of course, we know about the first weeks in the newborn's life. The day 1 to 3 is the colostrum. Baby gets colostrum and the breast feels soft. Day 3 to 4, the milk comes in, changes in color, volume also is increased, and the breasts are becoming feeding full. Now, in day 1 to 3 is the major problem, I feel. Most of the mothers are convinced they don't have milk. So again and again, reassuring, giving them the confidence, teaching them, this is the time you teach them, and then they make them understand that the baby is satisfied will help you to go on. And by day 6 to 7, baby may lose weight, and once breastfeeding established, the weight starts increasing. Fluid and glucose needs covered by extra in infant's body from birth. So already there is a proper storage. So you can tell the mother even the day 1 to 3, don't worry, even if the amount of milk is less. And by day 10 to 14, the baby regains the birth weight. Now, I think this picture, many of us know that in day 1, and it's very nice to show a chart to a mother like this. The baby's stomach is size of a cherry. It goes to the size of a walnut in day 2 and the size of an apricot and size of an egg. So this is just to teach the mothers that in the first few days, milk is not secreted in large quantities. It is secreted adequately with enough calories, with enough fat. So this is a good picture to tell the mothers. And in the first 24 hours, how does the feeding behavior of a normal newborn? Breastfeeding in the first hour may be followed by a long sleep. Okay, that's what usually happens. And then 5 to 12 times in the first 24 hours, babies vary and can depend on skin to skin and rooming in. So if you're not going to have skin to skin and rooming in, then the breastfeeding gets hampered. Day 2 to 3, frequency often increases 10 to 12 times, still variable. Then after day 3, when the milk comes in, maybe longer intervals between feeds, babies satiated, feeds become larger, feeds on average about 8 times in 24 hours. Mothers should keep babies close and respond as they show signs of readiness. Now in day 3, if the mother is not with the baby, what happens when the milk is full? Now she's going in for engorgement and infection. So that is important. When the baby is with the mother and she's feeding responsibly, what happens? It will self-regulate. So baby gets enough, and if the milk is more, it will regulate. But if the baby is not at all with the mother, there is no responsive feeding. Okay, so then the mother's engorgement, then other problems also come in. So baby who rooms in with the mother, who responds and gives according responsive, it gains more weight over the first 7 days. So this is another tool, maybe we can teach our staff to, this is like a checklist. Signs that breastfeeding is going well and signs of possible difficulty. So if you have to assess a mother, you can go through this checklist. The mother looks healthy, relaxed, comfortable, signs of bonding, definitely she's doing well. If she's looking ill or depressed, tense and uncomfortable, no contact, something is wrong. Baby again looks healthy and relaxed, she's good. The baby is not reaching out or restless or crying, it is bad. Breasts again look healthy, no discomfort, this is good. The breast having problem, it is bad. So this is a way you can have a checklist, to teach our nurses the skills so that they will be more alert on this. I'm not going to detail because I have some more slides to cover. Then always see the mother's response to infant's cues for feeding. Baby's needs for closeness and comfort. Signs of good positioning and effective latching. Suckling, swallowing, and milk transfer and assess baby's feeding pattern. Respond to the individual mother's and family needs, concerns, preferences, and values related to mixed feeding. Praise the mother if the baby is getting enough milk. Recognize that the mother may be overwhelmed with intense needs of her baby. And remind and reassure mother that the baby's needs and likes to be close to an arms, which is normal and appropriate. This is how every mother you should be counseling. Now, what are the practices to prevent and manage insufficient milk intake and transfer? Is again early skin to skin contact at delivery and early initiation. Skilled support of breastfeeding after delivery. This is where the BFHI and the UNICEF tells us that skilled people should be there to assist the mothers. And that is where an important role of each one of us is to train our nursing staff and health workers to offer the enough support in breastfeeding in the first few days of life, and practicing rooming in and then exclusive breastfeeding unless supplements medically indicated. Now, I just touch upon a few conditions like sore nipples and engorgement, because I think we need to understand. This is again a case study telling that her mother says that she's having a sore nipple. So what is this? This is a inverted nipple. So how do you help it? How do you help mothers with inverted nipples? Antenatally, we are not able to do much. But after delivery, you can build the mother's confidence, breast will improve. And then the babies, we should tell her that the baby is suckling at the breast and not the nipple. And let the baby explore the breast skin to skin. And we can teach her different positions. Underarm, yes, sir. So now the important thing in an inverted nipple is a deep latch. Okay, so a deep latch is a technique which we are now using for inverted nipples, not the syringing one, please note. And then of course the mastite, I'm not going through this because the lack of time. I think many people are aware, and these pictures tell us about the engorgement and the mastitis, and what to do for that. And how do you treat all this is actually because of poor attachment again. So again, latching and attachment is important, and then probably a mother would need an antibiotic. So that's all for the thing. And then only one more thing I wanted to tell you is the how cup feeding. I think you should know how to cup feed. Everybody should know in steps how to relate it. Then, of course, how to help a sick mother. Any ill mother, she can continue to breastfeed and encourage her to continue. Admit the baby along with the mother. If she has fever, give her plenty to drink. If she's not feeling well, then express the breast milk and feed by cup. And then find a companion to take care of. And then once the mother recovers, help her to directly breastfeed. And there are some medications, again, I'm not going into details, which we need to understand. There are certain medications which we not may be contraindicated, and there are medications which we can still continue and use alternative drugs. So I think we all hope to have a happy mother and baby when they leave the hospital, and I hope they exclusively breastfeed. Thank you so much. I ask Vishnu to take over. I'm sorry if I've taken some more time. Thank you very much.
Clinical practices 6, 9, and 10, and a few frequently asked questions in those steps. So, a case scenario: Mrs. B delivered a term appropriate for gestation age 3.2 kilograms healthy baby. At 50 hours of life, grandmother complains of not having adequate breast milk and is concerned if she should feed something else other than breast milk. So, signs: mothers think they do not have enough milk. Baby, not satisfied baby at breast, baby who cries often, refuses to breastfeed, breastfeeds frequently, breastfeeds for long periods, hard, dry, or green stool, and infrequent or small stool. And in a mother, breast did not enlarge during pregnancy. She feels the milk did not come in after delivery, or no milk comes with expression. So, common causes of insufficient milk in first weeks: the usual suspects: delay in initiating breastfeeding, none or little skin-to-skin contact, milk coming in delayed due to complications of delivery, maternal illness, or diabetes, poor attachment, and ineffective suckling. So after 2 weeks of age, perceived insufficiency and actual insufficiency. Perceived ones are the most common reason is again, mother thinks she doesn't have enough milk and gives up exclusive breastfeeding. Almost all mothers are able to produce as much milk as their baby needs, and many a times they would have continued breastfeeding if they had skill, support, and help. And actual insufficiency, in some cases, the mothers does have a supply issue. In those cases, assess for physical, psychological, or other causes in the mother. So listen to the mother and take a detailed history. Try to learn why she is doubting her milk supply, and try to build confidence by talking to her. Explore the mother's ideas and feelings about her milk and pressures she may be experiencing, and assess the infants whether the baby is getting milk or not. If the baby is able to empty the breast, baby is being fed exclusively or being supplemented. Assess the bigger picture. Check for the baby's weight and check if it's in the expected range. Has supplementation played a role? And look for the baby's urine output and stooling pattern. Assess for the mother's health, look for any risk factors for lactation problems. And again, assess latch, milk transfer, and check for positioning and attachment. So if there is a problem, make sure baby is adequately fed. This may require supplementation. Try to determine the cause. Has the problem been, since when the problem is there, and since when it has become apparent. Screen for breastfeeding management problems and factors related to the mother. If milk remained in the breast after feeding, determine the cause for baby's inability to remove milk. So for a question that may become handy in our assessment, for those few health situations where infants cannot or should not be fed at breast, describe in order of preference the alternatives to use. So this would be the sequence of alternatives. First would be mother's own express milk. Second would be donor human milk, like from breast milk banks. And third would be infant formulas. So what are the medical indications to give formula feeds? So a low birth weight baby weighing less than 1.5 kilograms, a preterm baby, hypoglycemia, signs or symptoms indicating poor breast milk intake and dehydration, metabolic disorders like galactosemia. Maternal indications, delayed milk production with poor intake by the baby, poor milk production due to breast pathology or breast surgery, severe pain with breastfeeding unrelieved by interventions, severe illnesses preventing a mother from caring for her infant, like cancer chemotherapy and all, illicit drug intake like cocaine and phencyclidine, active tuberculosis infection until 2 weeks of appropriate maternal therapy, and HIV only if artificial feeding only if affordable, feasible, acceptable, safe, and sustainable for 6 months. So in few cases, when the mothers who have made a fully informed decision not to breastfeed exclusively or have chosen to mix feed, make sure all mothers are informed about the risk and management of various feeding options in such scenarios, and also that they receive factual information in a sensitive and respectful manner. So these are the common supplemental options available in case we need supplementations. So donor breast milk from breast milk banks, as we discussed yesterday. So of late, there are few formulas which are breast milk based available in 3 forms: ready to feed forms, concentrated and powdered format, house milk based formulas, and hypoallergic formulas or hydrolyzed formulas only if medically indicated, like in allergies or health conditions like short bowel syndrome. So step 9, counsel mothers on the use and risks of feeding bottles, teats, and pacifiers. So this is another case scenario. Mrs. A is 20 years old. Her baby was born yesterday and is very healthy. She has tried to breastfeed twice, but her breasts are still soft. She thinks she has no milk and will not be able to breastfeed. When her baby cries, she puts her to the breast. The baby has suckled at her breast several times. Her husband has offered to buy her a bottle and some formula. He also tells her a pacifier will stop the baby from crying and plans to bring one to her today. So in such a scenario, counsel the mother on the use and risks of feeding bottles, teats, and pacifiers. Pacifiers undermine breastfeeding for the first 6 months. Infants who use pacifiers breastfeed less in 24 hours. Pacifiers should not be used at least until breastfeeding is well established and after 4 weeks of age. So this is one of the mandatory prerequisites that we do not encourage bottles or pacifiers in our hospital. So another question which can be handled is describe at least 4 elements of anticipatory guidance for a mother on calming or soothing techniques before or as alternatives to pacifiers. So offer the breast again, skin to skin with mother or support person. Hold the infant, walk, move around, rock, sing, interact with the baby, and massage also becomes handy. So step 10, coordinate discharge so that parents, infants have timely access to ongoing support and care. So before discharge, make sure the mother and caregivers are aware how to feed the baby, responsive feeding, and how to recognize feeding cues, as Madam was displaying earlier. The importance of exclusive breastfeeding for 6 months and continued breastfeeding, the risks of infant formula and other breast milk substitutes, how to get the ongoing support and help she needs. So breastfeeding is going well if baby is breastfeeding at least 6 to 8 times in 24 hours. Baby has at least 2 to 6 good wet diapers in a day. Baby has at least 2 to 4 tablespoon size bowel movements every day. You can hear your baby swallowing at feeds. Mother feels her breast softer after feeding, and nipples are not painful. Breastfeeding is an and mother feels breastfeeding is an enjoyable experience. So remember, if you go home from a health facility in 72 hours or less, the baby should be seen by a health worker in 2 to 3 days, and again at 10 days to 2 weeks. So any negatives to these steps are to be explained as warning signs to be taken care of. So follow-up care. So important follow-up times would be 2 to 4 days after birth and 10 to 14 days after birth when lactation is fully established. At these appointments, check the condition of the mother and baby, observe a breastfeed session, counsel the mother on any difficulties, explain feeding patterns, encourage exclusive breastfeeding. So describe at least 4 warning signs of infant undernourishment or dehydration for a mother to contact a healthcare professional after discharge. So usually a baby sleeping for more than 4 hours, baby apathetic, not so keen to feed, irritable or weak cry, always awake, never seeming satisfied, inability to suck, more than 12 feeds per day, most feeds lasting more than 30 minutes, no signs of swallowing with at least every 3 to 4 sucks, scant urine per day, no stools per day, and fever. So all these are signs for we need to be alerted about. So is there a system to follow mothers who needed support in lactation? Describe at least 2 locally available sources for timely infant feeding information and problem management. So follow-up visits by a healthcare provider and provide phone numbers to communicate. Primary healthcare centers, community healthcare providers, home visitors, breastfeeding clinics, nurses, midwives, and lactation consultants, peer counselors, mother-to-mother support groups. These are the options which we need to be making available for them. So this is a WABA action plan where they have elaborated peer counselors in the community by training mothers in the community, and again them referring these needy mothers to the health care system, and again healthcare system to make the contacts available about the community services available, and organizations making available protocols for and system for peer-to-peer support groups. That's all. Thank you, sir.
So what I am dealing with this section is I will be dealing with the process of MBFHI certification. Then I will tell you about the checklist used for the certification, then the scoring process and steps in conducting the assessment. So this will be about there will be about 30 slides and it will be last 1 hour. So that is it. So most of you will be familiar with all these things: ISPA, ISO, JSI, NABH, Bureau of Indian Standards, etc., etc. And we are now introducing a new standard, MBFHI. We are proudly introducing it. IAP Kerala, NHM, all these organizations, UNICEF, all these organizations together introduce a new standards in healthcare, that is MBFHI. So we are dealing with that today. So first, I will start with what is quality. What is quality? Quality is the degree of adherence to a predetermined standard, and we are now introducing a new standard called MBFHI. So let us start with the institutional structure. At the state level, there is a state level committee. There is a state level MBFHI committee, which consists of 12 members. It is headed by State Mission Director, chaired by State Mission Director NHM, DHS Kerala, Director of Health Service Kerala, DME Kerala, President of all these organizations that are with us will be there. Then I will be the convener. That is, I as the state quality assurance officer will be the convener of the committee. So the committee will be meeting every 2 months, and this committee will be giving the accreditation. Then there will be a district level committee. District level committee will be consisting of 10 members, and of these 10 members, DMO, DPM, RCH officer, or the IAP presidents, then NNF members, then KFOG members. All these members will be there in the 10-member committee. So it will be meeting as and when required. Then at the facility level, this is the most important committee and the grassroots level committee that conducts trainings and sees that the institutions follows the MBFHI guidelines. So institution committee is made by the it is no definite structure for the committee. Institution can form a committee and include all the persons they think are necessary. That is the basic institutional framework of this process. Then, so most important thing of this MBFHI is the assessment toolkit. So it is made with the extensive discussions between all the members, and it has incorporated all the quality elements into it. So it will be one of the best toolkits, I think, and we are trying to get a ISCO certification, but it is a long process. We will try to get a ISCO certification for this toolkit. So I am starting with the components of the toolkit. So the toolkit has multiple questionnaires or called checkpoint. And these checkpoints are grouped into 6 areas of concern called service provision, outcomes or KPIs, then the knowledge of the staff, knowledge and practice of the staff will be assessed, knowledge of the beneficiaries will be assessed, then the responsibility of the administration will be assessed. All these things are grouped as 6 areas of concern. Then comes the standards. The 10 standards, that is regarding BFHI plus 1 maternal standard. There will be total 11 standards. These 11 standards are divided into 130 checkpoints. These checkpoints are the basis of this assessment. So you give marks to this assessment, and based on the scores obtained for this checkpoints, the institution is getting accredited or not getting accredited. So this is the basic level of the assessment. Then these checkpoints are grouped together to form a checklist. It is only one checklist. One checklist consisting of 130 checkpoints, and it will be having 11 standards, 11 standards and 6 areas of concern. This is the basic tool that we are using to conduct the assessment. It may sound confusing to you, but it will become, when you become familiar, it will be easy. I will take you through the process. So this is a relationship. The area of concern is divided into standards. Each standard is divided into checkpoints, and checkpoints are grouped together from the checklist. From the checklist, once you score, put marks in the checklist, a scorecard will be generated. This is the process. So standards are divided into checkpoints. Checkpoints grouped together to form a checklist. Once you put scores in the checklist, a scorecard will be generated. That is the thing. So 6 areas of concern, that is service provision. Whether this tells us whether we are providing these services or not. The certain services are to be provided. It deals with whether we have providing these services or not. Then infrastructure, there are certain infrastructure things like breastfeeding corner, furniture in the breastfeeding corner, etc. All these things are dealt with in this area of concern. Then beneficiary knowledge and practices. This is assessed through beneficiary interviews. We will be conducting beneficiary interviews throughout the process, through the assessment, and these beneficiary knowledge and practices. Minimum number of questions are there because this is not a assessment to check the knowledge of the beneficiary. It is a thing to assess the practices that we have. So minimum number of checkpoints are there in the beneficiary knowledge and practices. Staff knowledge and competency is another area of concern. So more checkpoints are there in staff knowledge and competency. Then responsibility of administration. So certain things should be done by the administration of the hospital. So all these things are covered under this area of concern. Then after doing all these things, if we don't measure the outcome, we cannot find out whether we are in the right direction or not. There are certain outcomes like exclusive breastfeeding rate, early initiation of breastfeeding rate, etc. All these are grouped under outcome. So there are 6 areas of concern. These areas of concern are actually scattered in the checklist, and it will come out only in the scorecard. So you will not see it mark this area of concern, this area of concern. It is scattered in the checklist, and each question will be in one of these areas of concern, and it will come out once the scorecard is generated. It will show us that you got this percentage of marks in this area of concern, like that. Okay, this is a sample checklist. See, this is the most important thing in this assessment. You go for an assessment, this checklist. See, this is the beginning of the checklist. You see 5 important columns. First one is the reference number. Second column, you can see numbers. Each number 1, 2, 3, 4, 5, 6, etc. will be there. This represents the area of concern that checkpoint belongs. Then the third column is the checkpoint.
Amjad, 1 minute. Can you zoom it?
So it is full screen.
Better.
It is full screen, sir. I just want to tell the columns. It is full screen. Okay. So the third column is the checkpoint. So how to conduct assessment, I will tell that later. I am just introducing the checklist. So in the third column, there is a checkpoint. You can read the checkpoint and how to assess the checkpoint is given in the fifth column, that is means of verification. Okay. Fourth column, you should put the mark. Fifth column is assessment method. There are 4 assessment methods. I will be dealing with it later. Then the last column, it deals with, tells you how to conduct, how to find out that this checkpoint is met or not. So this is the 6 columns in that checklist. So this checklist will be shared with you. Just read the checklist. It's very simple. The main key is read the checkpoint, look at the means of verification. If all the things mentioned in the means of verification is there, you give the mark. That is all. That is very as simple as that. Any person can do the assessment. So you don't have to use any knowledge or any memory power or anything in this. You just have to read the first checkpoint, then see the means of verification. That is the answer for that thing. So if all the things mentioned in the means of verification is there, you give the mark. That is the thing. Okay, let us go by step by step. Pre-assessment activities. So this is the first step, creating the pool of assessors. That is what we are doing now. So nominate the assessors. The persons are nominated. Mainly doctors and nurses are nominated, and they undergo training. This training is going on. So this is you are here now. Providing assessor training. Assessor training is given. Training is followed by an evaluation. There will be exam of 1 hour duration. The details of which exam and all these things will be discussed in later in today by the Srihari. So training is followed by evaluation, and it will be one of the toughest exam that you have ever met. It is 80% marks is mandatory for this exam. So anyone who scores 80% marks will be a certified assessor. Those one who cannot go get 80% marks in the exam, no, don't worry about that. You can attend the next training and attend the exam. So it is a continuous process. So learning continues. So if in the first exam, if you don't get 80%, don't worry. The training is there will be a series of trainings, and you can attend the next exam and attend the exam. So then the certification of internal assessors will be done. Once the internal assessor is certified, the internal assessor certification will also be valid for 2 years, and there will be a retraining after 2 years, and they should get recertified after 2 years, because there will be some changes in the standards and the checkpoints after 2 years. So you have to undergo another training after 2 years. That is the thing. Certification validity of the assessor will be valid for 2 years. So selecting the assessment team. Once the state committee receives the application, the state quality assurance committee or the SQA unit in the NHM will select the assessors. There is a number based on the beds of the hospital. If there is more than 500 beds in the hospital, there will be 4 assessors. If there is 200 to 500, there will be 3 assessors, and below 200 there will be 2 assessors. So that is the criteria for having the number of assessors. Then another important criteria is it is said that at least 1 assessor should be a pediatrician. That is a mandatory criteria that we have put here. So in the assessment team, one of them will be a pediatrician. Then there are certain things which make sure that there is no bias in this. The assessor should not have worked in that hospital in the last 5 years. It is important criteria. So once we inform the assessor that you are selected for assessment of this hospital, the assessor has worked in that hospital in the last 5 years. The assessor should immediately inform the committee that I had worked in that hospital. So please absent me from the team. So that is a duty of the assessor to inform us that if he had worked in the hospital in the last 5 years, he should not voluntarily get out of that assessment. Then assessor's family members should not be working in that hospital at that time of time. So certainly close family members who are living with him should not be working in that hospital at that time. Then assessor should not have any share or partnership in that institution. That is another important thing. So this all these are to the credibility of the certification. So all these should be strictly followed. Then how the assessors will be selected? The assessors will be selected in a random process, and the assessors cannot demand that I am ready to go for assessment of this institution, or that institution. It will be selected by a random process. So this will also increase the genuineness of the assessment. Logistic and communication. So the assessment schedule will be communicated to the hospital 1 week prior to the assessment. So only the day this assessment dates will be discussed with the assessors, and the assessors convenient dates will be taken. So but the convenient dates of the hospital cannot be taken as it will be a Herculean task if we have to get the convenient assessors and convenient dates of the hospital. So convenient dates of the assessors will be taken, and the dates will be communicated to the hospital 1 week prior to the assessment. Then the hospital has to take printouts. If there are 3 assessors, 3 printouts of the checklist. Checklist may be 10 pages. So the hospital has to take 3 printout of the checklist during the assessment, and it should be given to the assessors. So the hospital, it is the duty of the hospital to communicate in advance to the departments that such an assessment is taking place. So the department should not be surprised when the assessors are there. So the hospital should communicate in prior to the assessment that this all these things are going to take place, and they should not be surprised to see the assessors in the department. Then more important part that should be done by the hospital is that hospital should arrange a computer with the internet for online reporting of the results. The result is reported that day in the hospital itself. So there should be a computer with internet for reporting the online reporting of the results. The results will be reported to the State Quality Assurance Committee through a Google form, and the hospital has to arrange for the computer with the internet for this purpose. The assessment. So the assessment usually starts with the opening meeting. This is the most important part. So opening meeting. So once the assessors reach the institution, there will be an opening meeting. Opening meeting will be held at the institution by the institution, and they decide whether it should where it should be done, which all people should attend the meeting, and the main motive of this meeting is introduction of the assessors. Assessors will be introducing themselves to the team of the hospital, and the team will be introducing themselves to the assessors. Then if there is some assessors, we are planning to have some observers for the initial 4 assessments, so that the assessments is conducted smoothly. So initial few assessments may be having a few observers, but other later it will not be there. So to see that the assessment is conducted smoothly in the initial phases, there may be some assessors from the state quality assurance unit, but later it will not be there. Then the assessors will tell them the outline of the responsibilities, how they are going to conduct the assessment. All these things will be explained to the hospital management during the opening meeting. Then the hospital management can have a PowerPoint presentation and tell the assessors what they were doing. So what they were doing, etc. And they can tell the assessors about all the plus points. But the assessors be cautious. The hospital present in the opening meeting will not be there. So don't get fooled by the presentation, but it will give you a overall idea of what is going on in the hospital, how prepared is the institution. All those things you can assess during the opening meeting. Opening meeting is only an introductory one, that so marks should not be given based on the opening meeting. Then assessors should confirm that all the resources and facilities needed by the assessment team is available. That is, make sure that computer is ready for reporting. Then the checklists are available. All these things are available. Make sure all these things are available. Then they should announce that when there will be a closing meeting. Closing meeting after the assessment is over and reporting is done, there will be a closing meeting with the same members. The opening meeting is held, and in that meeting the assessors will share the results with the institution. So the assessors in the opening meeting itself, assessors can tell at approximate what time there will be the closing meeting, so that the closing meeting can be arranged at that time. So some suggestions for a good assessment. So do's. praise the good practices. Assessors should be generous in praising the institutions in doing their good practices. Share the breadth. They can tell the institution that there is some good practices like this going on in some other institutions and all. So that will help them to improve better. Then before observing any procedure, take permission. So ethical thing coming in. So without permission, you cannot do anything. Before observing any procedure, take the permission for the concerned person. Then arrange the printout, stationery, etc. before it. Be punctual and on time and committed. So make sure that if we tell that assessment will start at 10, the opening meeting should start at 10. It should not be delayed. Make sure that you reach the hospital in time. The most important thing that you do not do is do not criticize. So even though you find faults in the hospital, don't criticize them. Okay, it is a hand-holding process. You are not a superior of that hospital. You are only a fact-finding team. So your mission is a fact-finding and not a fault-finding one. So make sure that you don't criticize the team. You find the facts, report the facts. Don't scold the staff nurse. Don't scold the cleaning staff. No, you don't have the authority to do that. So be sure and don't criticize. Don't scold any of the staff. Do not talk about gaps of one place in another place. So if you find one gap in one place, don't tell it. Tell the other department that there was a gap in that department. So that like that it should not be done. So once you see the gap, it should be in your mind only. Don't breach the privacy of the patient. So always respect the privacy of the patient. Then another important thing, don't ask for any undue privileges. I know it will not take place, but there are some instances during other quality certifications that undue privileges are asked by assessors. Even so, it will not take place, but it is a word of caution. The normal functioning of the department staff should not be hampered. So hospital is always functioning for the patient. So normal patient care should not be hampered during the assessment. The assessment should be converted in such a way that normal patient care is not affected during the assessment. So how to conduct the assessment? Once you complete the opening meeting, the assessors go for the institution visit. You want to visit the gynecopedy, pediatric OPD, gynecology ward, labor room, NICU, SNCU, etc. You go for the assessors go for a visit to these areas. So the assessors should not go alone. They should go along with the hospital management. Hospital management should arrange a team to go with the assessors. So the team should not be very large. If there are 3 assessors, 1 or 2 members from the hospital is enough. So 5 members is also a large team. So maximum 5 is the team. More than that will be cause overcrowding. So a team should be there. The team should be visiting the institution, seeing the institution, what is happening in the institution, and during this visit they are conducting staff interview, beneficiary interview. All these things are conducted during this visit. Okay, how you conduct the assessment? Once you have the checklist, there is a column, 4th column in the checklist. I will show you 4th column in the checklist where it will tell you what you have to do to assess a checkpoint. It is observation, whether you have to do it by observation, whether you have to do it the staff interview, report review, or patient interview, or beneficiary interview. It will be in the in the 4th column. It is written there that how you should conduct the interview, conduct this assessment. So it is there. So you can have the checklist with you. Go with the checklist only. Don't try to by heart anything. It is impossible to by heart all these things. So you go with the checklist. Do what is written in the checklist only. Okay. So there is 4 means of assessment methods. That is observation, staff interview, code review, and patient interview. See the checklist also. See this 5th column. In the 5th column, it is written. See the first checkpoint. Health facility has a written breastfeeding and breastfeeding infant feeding policy. So how it should be verified? It is verified by assessment method uses record review and staff interview. Record review, you can see the breastfeeding policy, and the breastfeeding or infant feeding policy. Is there a policy there? So if it is in paper, it is there. Then you ask the staff about this policy, whether they are aware of this policy, they know that their policy is there. So most of the time, these policies will be there. They can print it one day before the assessment and show you that it is there. But that is not the thing. The staff should be aware that there is a policy and they are following it. That is important. So how you assess it? It is through record review and staff interview. So what you have to look is availability of printed copy of the infant feeding policy. So once you show and they show you the copy of the infant feeding policy, it is they are sure that there is a policy is there. Okay. So there is another question, and I will explain it later when we do the assessment. Compliance to the rules. How you give marks. So full compliance is 2 marks. So full compliance is 2 marks means all the requirements in checkpoints are met. That is in the means of verification column, certain thing will be written. So if that is met, you have to give the full compliance. There is no, you cannot say and more thing is needed than what is written in the means of verification. If something is written in the means of verification, that is enough. Okay, you cannot say less is required. What is required in the what is written in the means of verification is required to get the full compliance. Okay, you don't have another option. So if it is anything written in the means of verification is there, then it is there. So okay, you have to give the full compliance. Okay, all traces given in the verification of the means of verification are available. Then intent of the checkpoint is meeting. Okay, that is the full compliance. Then partial compliance, I will tell you, in breastfeeding policy and all, partial compliance is not there. If the breastfeeding policy is there, it is there, 2 marks. If it is not there, it is 0. So, but certain most of the checkpoints they have multiple traces in the means of verification. So in that cases only partial compliance come into place. I will explain it later. Some of the requirements of checkpoints are meeting. At least 50% of the traces in the means of verification are available. So if 5 points are mentioned in the means of verification, and if 3 points are available, you give 1 mark. Okay. If 2 points are available out of 5, what will be the marks? The marks will be 0. So if anything more than 50% is 50 or more than 50% is 1. Okay. So if there is 10 points and if there are 5 to 9 are available, the mark is only 1, not 2. If 9, even if there are 10 10 traces and if 9 are available, the mark is only 1. You cannot give 10. Okay. So you can give 2 only if all the 10 points are satisfied. Okay, that is clear, I think. So up to 50%, if there is 49%, the mark is 0. Okay, of the 10 points, if there is only 4 points, then the mark is 0. Okay, if there is 5 to 9, the mark is 1. Or if there are all the 10 points are there, then only the mark is 2. Okay, now it is clear. Now you understand this, that the exam is very tough, right? If you do 99% in all the checklists, what will be the score? The total score will be 50%. Okay, okay. So all the checklists you do the same like 90% in all these checklists, then the total score will be all the checkpoints you do 90%, then the total score will be 50%. So many of the checkpoints you have to get full marks, otherwise you will fail in the exam. That is the thing. So it is a tough exam. Although 80% mark is read, it is a tough exam. Okay. So you may be confused about giving partial marks, full marks, etc. So see the highlighted checkpoints. The summary of breastfeeding infant feeding policy is posted or displayed in antenatal, pediatric OPD and immunization clinic. This is the third column. So that is the checkpoint. How you will verify? It is verified by observation, staff interview, and patient interview. Observation is the main important thing. If you see it, then it is displayed. So staff interview, patient interview can be done away with. But if you use 2 methods, you can see that yeah, this is there, because if you ask the patient whether it was installed yesterday. Then if you see that it is installed yesterday, it is not the process. So installing something for one day is not the thing. So it is installed 1 day, 2 day before, then it is not the thing to do. It should be done earlier, and there should be a process there. So, okay. So then you go to the means of verification. It states that display board should be present in OPD 1, antenatal 2, postnatal ward 3, labor room 4, high dependency units like NICU and SNCU. So 6 areas, total 6 areas. So no, don't worry about that. What is written in the means of verification, the checklist given to you should be done. So don't go with it. Here it is 6 points. So give full marks only if all that 6 things are there. Okay, 6 points are there. If there is only 5, the mark is 1. If there is only 4, the mark is 1. If there is only 3, the mark is 1. If there is 2, the mark is 0. Okay, I think it is clear. Okay, if there is 50 or more than 50% in the traces given in the means of verification, the mark is 1. Okay, if there is 100% only, the full marks will be given. Okay, that is the way you have to give the marks. I think it is clear. When it will be more clear when you conduct the assessment by yourself. Okay, so you can in the exam that is following, you will be given a case scenario, and it will be more clear after that exam. In the exam, you will learn how to put the marks. So the exam will be another way of teaching you. So the exam in this case scenario, this will be given that the board is there, and how much marks will be given. How much marks you go. That is the way the exam is conducted. So that will help you to learn this assessment more clear. Then once the assessment is concluded, then there is some criteria for certification. There is mainly 4 criteria for certification. The total score of the institution should be 80%. Then I have told you there are 6 areas of concern. A score in each area of concern should be greater than or equal to 70%. Criteria 3 is score of each standard. There are 11 standards I told you earlier. So score of each standards is greater than or equal to 70%. Then there is a 4th criteria. There will be 2 mandatory standards. Standard number 6 and 9, and there should be 100% marks in that 2 criteria. That is about use of breastfeeding substitutes, then use of milk bottles, pacifiers, etc. So if you see any of these things in the institution without a prescription, then the institution has, you can make sure that the institution has paid. So so there are 2 mandatory standards also, 6 and 9. So if the institution meets all the 4 criteria, the institution will be get MBFHI certification. Okay, if all these 4 criteria are met only, they will get full certification. If they meet only 2 criteria, from 2 criteria means criteria 3 and 4 is mandatory. So standard 3 and 4 should be there. But in 1 and 2, if they don't get the 80% and 70% also, and if they score more than 50%, they can we can certify it with conditionality. And conditionality is certification is valid only for 6 months, and they can correct the gaps that they see in the assessment, and they can this will be verified by an assessor. So after that, we will give them full certification. So there are 2 certification, full certification and certification with conditionality. Full certification is valid for 2 years. Certification with conditionality is valid only for 6 months. Okay, if they meet all these 4 criteria, they will get fully certified. If the 3 or 4 criteria are met, if only 3 or 2 are criteria is met, they will get a certification with conditionality. Okay, it is and it is written in the process note, so everyone can go through the process note before going for assessment. It is very clearly written in the, all these criteria are clearly written in the process note used for certification. So once you conduct the assessment, what you have to do? Once you complete the assessment and come back, first thing you have to put marks in the checklist that you are taking with you. The paper checklist, you put the marks. So, okay. So there are 3 assessors and the checklist is the same. So how will you put the marks? You can either split the questions among yourself. There is 130 questions, so you can split it among 3 of you, or you can read each checkpoint and reach a consensus and put a mark there. So it is up to you. Either you can split the checkpoints among you, or you can reach a consensus in each checkpoint and put a mark. It is up to you to decide. So usually it is difficult to reach a consensus there. So it is better to split the checkpoint into 3 and you put them, each person puts marks for a certain number of questions, and it is compiled together. Okay, once you put the marks in the checklist, in the paper checklist, you bring it to the computer, and there is a Excel toolkit which is provided to you. Okay, so you enter the marks 0, 1, 2 in the Excel toolkit, 0, 1, 2 in the computer. So in the space provided, then the scores will be generated as will be self-generated automatically, and the scorecard will, you can see the scorecard. So once you put the marks in the Excel sheet, the formulas are added into the Excel sheet, so that the marks will be generated automatically and you will see the score sheet. Okay, interpreting the scores is very easy because the score sheet will be in front of you. Once you put the marks, the Excel will generate the score sheet. This is the score sheet. Okay, this is how the score sheet will look like. So the hospital score will be there. Total score will be here. Each area of concern based score will be there. So 6 areas of concern based score will be 1, 2, 3, 4, 5, 6. 6 area of concern based score will be here. Then score of each standard will be here. Okay, these 2 are the 6 and 9 are the mandatory standards. So it is easy for you. Once you put the marks, the Excel sheet will generate everything for you. Don't worry about any calculation. The Excel sheet will be doing it for you. Okay. So you have to put only 0, 1, 2. The Excel sheet will create the score for you. So from this you can see that the criteria is met or not. So we will be adding some functionalities into the checklist, so that once the criteria is met, it will give you a green color. So if criteria is not met, the scores will be in red color. So it will be easy for you. Look at the checklist, you can see that the institution is certified or not. If there is some red color marks in the checklist, then you can make sure that the institution is not certified. Okay, so you just have to put 0, 1, 2. Then the Excel sheet will do all other things for you. So the conditionalities will be added into the formulas of the checklist, so that color changing will be there. So we tried to make it very simple. I think it works very well. So reporting, prepare the report in the format provided. We will provide you with a format, and you have to have a hard copy of the report. The hard copy of the report is in that format, and the format will be provided to you. Once you complete the report, same have to be embedded into a Google form. Send to you. Google form will be linked will be sent to you, and you have to enter that report, that scores into that Google form. Then once you submit the Google form, the report is with the state quality assurance unit. So the state quality assurance unit will receive the report before you start the closing meeting. Once you submit the report to the state quality assurance unit, it is final. You cannot make any changes. So that is why we are asking you to submit the report before the closing meeting. Then the closing meeting, you will be telling them the gap. So once you are there, you are telling the gaps, they will be telling we have this, we have that. All those things will be there. So the decision is final before that. So the decision is made final before the closing meeting. Then the assessors have to sign a hard copy of the report, and it should be sent by post or by hand to the state unit, NHF state unit. Then it will be put before the state MBFHI committee, and the MBFHI committee, after verifying the scores, will be giving the certification. So we are planning to conduct MBFHI committee every 2 months. More frequently, if required, we will conduct. If more institutions are there, we may conduct it. Then, then we conduct the closing meeting. In the closing meeting, we provide a copy of the mark list to the institution, so they know where which are their gaps, what what went wrong for them, what is good for them. They know their marks in the closing meeting. In closing meetings, or they can close the gaps. So it is a hand-holding process. It is not a fault-finding exercise. Make sure that it is not a fault-finding exercise. It is a duty of the assessors to make sure that it is not a fault-finding. It is a hand-holding process. After the assessment, the institution should be more confident to face the next assessment. That is the thing. So it should be a hand-holding process. You should not scold the people. You should not find fault. You should handhold them to achieve these targets. Okay. So this is the format of assessor report. This will be given in printed format. You can fill this name of the assessors, all these marks, then major gaps observed, areas of points of improvement. Then you write the scores, sign, all the assessors to sign it, put it in a cover and send it. I send it either by post or by hand to the SMD, who is the chair of the MBFI certification committee, and it will be put in the next MBFI committee or BFHI committee. Okay, I think that is clear. So the accreditation process, institution should apply to the SMD, who is the chair of the MBFI committee, through district MBFI candidate. They should send the application through the district committee only. District committee should verify the application before submitting it to state committee. District committee verify that the required documents are there, and they submit it to state committee. Then the state quality assurance unit will appoint assessors to conduct the assessment. The assessors will conduct the assessment and submit the report to SMD through online form and hard copy. It should be made. Then the report will be placed before the MBFHI committee, which will be held every 2 months, more frequently if required. Then the MBFHI state committee will grant the accreditation to the institution. Okay, that is clear. I think that is clear. So validity of certification, the certification is valid for 2 years. Once you get the full certification, certification is valid for 2 years. Then before the end of two years, 3 months prior to the end of 2 years, the institution should apply for recertification. So the assessment will be conducted, and the certification will be renewed before the end of 2 years. So the institution will have a continuous certification. So the institution should apply at least 3 months before the end of certification. Then certification with conditionality is valid for 6 months. So before 6 months, the institution should close the gaps and inform the district MBFHI committee that we have closed the gap along with the evidence of photo evidence or something like that. And one assessor will be sent, not the full team, based on the number of gaps. One assessor or maybe 2 assessors will be sent to the institution, and it will be verified and find. And if it is satisfied, then the certification will be given. Full certification will be given. Once institution fails in an assessment, it is we don't want any institution to fail in the assessment, but it can happen. So once the institution, if institution is not at all prepared for the assessment, the institution should fail. So once the institution fails, the institution can reapply only after 2 months. So they can close the gaps, wait for 2 months and reapply. Then a new assessment will be conducted for the institution. But in this case, if the institution fails in an assessment and they reapply after 2 months, the district committee should be sure that the institution has improved before going for another assessment. Though it is a responsibility of the district committee to make sure that the institution is not blankly applying for the assessments continuously. They are improved. They have made the processes clear before going for the reassessment. That is one of the responsibility of the district committees to see that it is happening. Okay.
Just one point. Actually, after getting certification, they should do a self-assessment at the end of 1 year and they should self-certify.
Oh, yeah. I didn't mention. I mentioned. Okay. Every year, the thing is, one more thing I forgot to mention here. The thing is, once for applying, first the institution has to run the checklist by their own, and they should self-certify that they have certified. So the institutional community should run the checklist by themselves, and they should themselves satisfy that we are ready for the assessment. Then only they can apply for the assessment. That is the first thing that is needed for the assessment. So for applying for the assessment, you should the institutions will self-certify that. The institutional committee should see that it is okay, and then only they can send the application. Likewise, at the end of 1 year, the institution should do the process themselves once more and inform the district and state committee that we have conducted the assessment, we have got the following scores on self-assessment, and the certification will continue. So if the institution fails to submit that self-certification report after 1 year, then they will lose the certification. Now I forgot to mention that in this slide. So thank you, Srihari, for reminding me. So what is the process that you are going to do in a institution? First thing, setting up the committees, start the training, internal assessment, and gap analysis. So first you constitute the committees, train the staff, start the internal assessment, find the gaps. Okay, prioritize the gaps, close the low hanging gaps. That is low hanging fruits first. So easy to close gaps should be closed first. Then the gaps should be prioritized and closed. Action planning and prioritization of the gaps is done, and the gaps are closed. Then you measure the key performance indicators. 7 key performance indicators are there. So you make sure that you are measuring key performance indicators like explosive breastfeeding rate, early initiation of breastfeeding rate, all those things every month. Then you conduct the self-assessment using your own assessors. You yourself conduct the assessment, and the institutional committee will verify the score and satisfy themselves that we are ready for assessment, and they self-certify that we are ready for the assessment. And then say after self-certification, they will apply for MBFHI certification through the district committee. That is the process. Okay, so the process should start from the institution. It is a not top-down process, down to top process. The the process should start from the grassroots level and come up. That is the process that we are. Okay, thank you. I think I covered most of the points.
Constraints, I have to rush through the slides, I think. Actually, we have learned from so many presentations that breastfeeding is not only the mother's responsibility. It is not her responsibility alone. If she is failing in breastfeeding, ethically, the health workers have to blame themselves too. That's what I believe. And in this presentation, I'm concentrating on communication skills, leadership, and teamwork. And as a healthcare worker, we are all trained in communication. We are trained to look for and fix problems, but are we succeeding in that? We have to think that. The good communication means respect for the women's own thoughts, beliefs, and culture. We should not tell or advise a person they should do what we think. And health workers should be able to do more than just offer information. You have to help the mothers to look at the cause of any difficulties, let the mother think and let her find out solutions and suggest a course of action to help to fix the problems. Sometimes just offering assurance, she will improve and she will be doing well. And actually, counseling is a way of working with people in which you try to understand how they feel and help them to decide what to do. We have to help them to decide. We should not give advices. That's the important thing in counseling or in communication. And a breastfeeding mother may not be able to talk about her feelings easily unless she develops a trust with the healthcare professional. That's the truth. And you need the skill to listen and to make her feel that you're interested in her. This will encourage her to tell you more. And as the trust develops more and more, she will disclose more about her difficulties. And these communication skills not merely consist of listening and learning, but it is of building confidence, giving support, arranging suitable follow-up and support. All these comes under communication skills. And we have to follow all these communication skills, like use helpful nonverbal communication, ask open questions, encourage the mother to talk, empathize with the mother rather than just showing sympathy, and avoid words which sound judging. And for nonverbal communication, we have to keep our head level with the head level of the mother. We have to assume a sitting posture better. I think it's better rather than a standing posture. A standing posture gives the cue that you are in a hurry. And if you are sitting near the mother, it conveys the idea that we have some time to spare with her. So we have to remove all the barriers like desk folders in between the mother and baby, mother and us, and we have to look into the, we have to maintain an eye contact with the mother, and we have to start talking. And we have to pay attention to the mother. We should not get distracted in between. We should not look at our watch in between. That means we are in a hurry. So we have to touch the mother only in appropriate ways. Better to touch on the hand and arm. And if you want to see her breast, and if you want to touch the breast, you have to get permission before doing this. And you can just greet the mother upon arriving, like, "Good morning, Anita. How is breastfeeding going you for you and the baby?" Like that, we have to greet the mother and we have to start the conversation. Slowly build the trust and go about conversations. So we have to ask open questions, and that was stressed in many presentations. Like, open questions usually start with how, what, when, where, why. Example, how are you feeding your baby? That's an open question, so that the mother can tell more about the feeding experience. So you need to assess the situation and difficulties faced by the mother and ask questions that encourages the mother to talk. And we should not ask closed questions, that we should be careful. So that won't be giving much information. And these closed questions usually start with, are you, did you, ask the baby. Sometimes we can suggest the correct answer to help the mother to talk more. Then we can use responses and gestures which show interest to encourage the mother to talk. So show we are interested in what mother is saying. Use responses such as nodding, smiling, simple responses such as go on, please go on. Like that, all this will encourage the mother. So we can reflect back what the mother is saying. Sometimes this reflect backing is needed. So this can help the mother to clarify her statement. And we can mix the reflecting back technique with the other responses. And the health worker reflects back what the mother says so that the mother gives more information. For example, the worker is asking, he seems more hungry just for about a week. And the mother replies, yes. And my sister is telling me that I should give him some bottle feeds as well. So we can reflect back like this. Your sister says that he needs something more. Then the mother will say, yes, which formula is best. And like that, the conversation will go on and the mother will tell her idea, what is in her mind. And we can proceed with our counseling session. Then you have to empathize with the mother. In this point, we have to see the difference between sympathy and empathy. Yes, we should not show just sympathy. We have to empathize with the mother. Empathizing means we have to show understanding towards her feelings. That is, looking from her feelings, looking at her feelings from her own point of view. So empathize with her good feelings too, not just bad feelings. And we have to find out how she feels about the situation and ask the mother to give more facts about her difficulties. So you have to avoid judging words like right, wrong, well, bad, good. It's a problem. Like that, we should not give any judging words. And these judging words can make a woman feel like she is wrong or something wrong with the baby. So then good communication skills help the mother to feel good and confident to carry out her decisions and to help her to build confidence and accept what a mother thinks and feels, and recognize and acknowledge what is right, and give practical help. Sometimes we have to, in most of the cases, we have to demonstrate how to feed the baby, like the positions. It even starts from the antenatal session itself. In Sangeeta Madam's class, he elaborately told about the antenatal classes, intrapartum help and postpartum help. Indumati Madam also stressed about it. So I'm not going into the details of that. You have to provide relevant information using suitable language. The local language, slangs can be used. And you can use or make one or two suggestions at a time, rather than giving more suggestions at a time. Then accept what a mother thinks and feels. Like we have to accept the mother without disagreeing. Does not mean that we agree she is right, but first we accept what she is saying and give time for her to correct the information in later sessions. So help the mother to trust you and encourages her to continue the conversation. Unless the mother trusts us, she won't open up. So building trust is very much important. So recognize and acknowledge what is right. So we have to recognize and praise what mother and baby are achieving, and tell the mother how well the baby is attaching, and point out how clever the baby is in detaching himself after feed. If the baby is satisfied with the feed, he will automatically detach from the breast after feeding. You can point out that to the mother. Then give practical help. That is, we have seen in last presentations, like milk will flow better if the mother is comfortable. And we have to offer another pillow rather than letting the mother to lean over to the baby. That will cause back strain. So offer to hold the baby while he goes to wash. We have to offer help from our side if she wants. And may need clear practical help. Example, how to express milk, how to hold the baby. All these things, she needs practical help, especially if the mother is a primary mother. And provide relevant information using suitable language. You have to first find out what she needs to know at this time. Use suitable words that the mother understands. Do not overwhelm her with information. We should not give lots and lots of information at a time. We have to give suggestions, not commands. And we have to provide choices and let her decide. Example, feeding positions. We can demonstrate 1 or 2 or 3 comfortable positions, and she can select from that positions. And do not tell her what she should do. And you have to remember, you have to limit suggestions to 1 or 2 at a time. Then arranging follow-up and ongoing support is very much important. Learn what is available from friends and family members. Offer a time to see or talk to her again, especially during the postnatal visit. When the mother is coming with the baby for the immunization, encourage her to see you or another person for help. And the nurse in the postnatal clinic or the obstetrician in the postnatal clinic can talk with her in this situation. And refer to community support groups if available, and refer her to more specialized counseling if needed. And we can just see some examples of closed questions and open questions. Closed questions, health worker is greeting the woman. Good morning, Anita. I am staff nurse so-and-so. Is the baby well? Then mother says, yes, thank you. The next question, are you breastfeeding him? Then again the mother says, yes. Then are you having any difficulties? Mother says, no. Is he breastfeeding very often? Mother says, yes. This will not give further information. Then just look at these open questions. You have to use always open questions. So you have to remember the communication is always 7% of spoken words, 38% of voice and tone, and 55% of body language. So the leadership skills also counts. Like there should be a team leader for coordinating all these. If a lactation counselor is available, it's well and good. We can use the help of obstetricians, pediatricians, and nurses. And we have to plan strategies specific to the number of breastfeeding mothers in the hospital, and we can hold the discussions and review meetings in between. And we can form support groups with the lactation counselor and student nurses. And we can also offer peer support groups with the other mothers. Then you have to respect the mother, and the level of leadership is not at all important. The role of the leader is very important. So there is a definite role for the family too in a successful breastfeeding. So actually, this is a teamwork. That's why the government has identified that teamwork, and we have included all the healthcare professionals dealing with this breastfeeding. So thank you, sir.
So this internal assessment or the MBFHI monitoring tool is just a checklist whether to see whether you are at par with the global standards of MBFHI. And this institutional implementation committee has to be formed, and with this everything, including medical director, the pediatrician, neonatologist, nursing superintendent, the nurses in charge of labor room, attendants, pharmacists, and PRO. And what we have to do is, Dr. Anjita said, setting up committees, internal assessment, action planning, measuring the key performance indicators is given in the external evaluation form, self-certification, and after that apply for the certification through the district committee. And this internal assessment is complete, can call for external assessment, which occurs 5 times a year. And this has to be followed every 6 months to 1 year, maybe 1 year, to maintain this status. This is an important slide which the Rajmohan sir wanted to tell you about the difference between the monitoring tool and the external evaluation. So the monitoring tool is the aim is at the institutional level. You should handle lactation failure and give quality care to the patient. Whereas external evaluation is to motivate the health workers to give the public a quality care. And there is a quality element in the monitoring tool. There is a program to improve the quality of the care to see whether achieved all the MBFHI points. And external evaluation is a criteria satisfying checklist. The written policy covered all the points, displayed like that. And there should be measures to the monitoring tool measures the progress of 10 steps. But the external evaluation evaluates whether the hospital meets the global criteria. And monitoring tool identifies areas needing improvement and helps in planning actions. And whereas external evaluation also saying, but it also used to decide if the hospital should remain designated as MBFHI. But monitoring tool can be done by internal assessors, those who are pediatricians or gynecologists or the nurses in the hospital. And that can be organized by the external also, or the district task force can decide on that. And naturally that will be very inexpensive because all the assessors are from the same hospital. But external should be done by the stakeholders in association with the government of Kerala. That's what Dr. Anjit has said now. And it is a costly affair, but fortunately our NHM has taken up the cost. And this monitoring tool should be done every 6 months to 1 year, whereas external evaluation maybe every 2 years. And monitoring tool has to be continuous and sustainable. External evaluation may, even though it is one-time affair, but as Dr. Anjit has said, every year we have to be a self-appraisal. This monitoring tool has to be assessed and sent to the government. And yesterday there was one discussion on the problems with the government and private sector. This slide I just added for that. This IMS Act government sector is fully compliant. I am doubtful whether private sector can do that, but have to do. And this formula of it, what Amjit has said, Dr. Amjit has said about the 100% internal criteria. I don't know how it will happen, especially in tertiary care centers. And the staff training, antenatal care counseling, follow-up, and WhatsApp group committee. All these are possible with the private sector, but I don't know how much it will be success with the government sector. So that is what I want to tell you. And this is the assessment method, how the monitoring tool has to be assessed by interviewing the clinical staff, records by checklist, and then comments from the mothers. This also can be done internally. All this has now there's no point in telling all this because the sentinel indicator, all this Dr. Anjit has said, and all this what we have to do, we have to look for is given in the external evaluation form clearly. So you have to go through the external evaluation form. That itself has to be done in your hospital monitor or internal. That is all what I wanted to say. Thank you.
Great thing, and we have to comply to the international standards, and there is a breastfeeding policy for the hospital from NHM MARC program. It is available, and there should be a nodal person or a committee. That was also stressed. And what about the pharmacists and chemists who are, and the supermarkets, which is not coming under the IMS Act? And the imprisonment or fine of the IMS Act is also very less. I think we must have something like in the representation, we should put it up. And in the antenatal classes, the father also should be there. That is what I want to stress. Usually it is a mother and one other lady who is coming, maybe a neighbor is coming or somebody is there with the mother. But if the father is also there, it will lead to the family participatory feeding. And we always propagate the advantages, but there should be a slide which is telling about the dangers of the infant formula. I think this will catch more attention. And in the latch score, the first feed should be recorded, and audible swallowing is difficult. We have done some lot of trials in our and our experience is that instead of audible swallowing, make it assessment of milk transfer. It can be seen, it can be felt, or it can be heard. And the type of nipple has no relevance now. And if the nipple is flat, what is the adaptation that has done? That is my suggestion. And these nursing pillows, we should propagate. And this donut air pillow for cesarean mothers, if they sit on it, it is very good. And this stomach capacity and the U-hold, the cross cradle, and making the baby in the prone position. That is what we learned from the animal kingdom. I think we should capitalize on this. Then the UNICEF and WHO has given the guideline on when we can prescribe formula. I think I can share this with all of you. It is all given there. And there should be zero separation unless critically ill. That is one. We used to separate even COVID mothers and babies and all. And zero alternate feeding unless medically indicated. And there should be a the compliance committee should be checking the compliance in each hospital. How many sick and small babies were there? How many babies were initiated within an hour? But only thing, one thing which caught my attention is this slide. That is, when it comes to the data, the Kerala data, this is white means no data is available. I think we should look into it. That is all. Thank you very much.